Right, how are you doing? Here's hoping that all is well with you from wherever part of the world you are watching us. It's always a pleasure having you on the program. It is In Focus. And my name, as always, is Eugene Anangwe. Now on the program we get to discuss various issues concerning various topical matters of concern to you, and of course with an aim of just bringing them on the table to make sense out of them. And tonight on the program we are talking about one of the very important matters, and that is the issue of medical malpractice, or sometimes you could call it the issues of doctors and medical practitioners behaving badly. That is what we'll be talking about right here on the program. We'd love to hear from you, and of course it's a conversational show. All you need to do is tweet us by always adding the hashtag InFocusRW. It helps us to track your tweets and be able to sample them right here. What we want to hear from you on the program tonight is your experience. If you have gone through this, if you've been to a medical facility and you did not appreciate what happened there, we'd love to hear your experience, and of course we'd love to find out what can be done to solve these particular issues. It's a discussion that definitely is very important. We had expected to have the Minister of Health, but of course we understand it is World Cancer Day, and of course due to the activities involved in this day, she was not able to make it on the program. However, we have none other than Dr. Emmanuel Rudakemwa, who is the chairperson of the Rwanda Medical and Dental Council. Thank you for joining us on the program.
You're welcome.
You're the regulator for medical issues, right? And of course also with us in the program is none other than Sam Ruzin, who is a professional dental practitioner. Thank you for joining us on the program.
My pleasure to be on the program.
Perfect. Now, for me, Dr. Rudakemwa, one of the things that when I was preparing for this conversation and the time I made a call to you, understanding the role of your institution or the council, first of all, for those who have not heard about it, this is a professional, administrative and jurisdictional body that defends and oversees the medical profession. Very important responsibility. However, it is not really known by most Rwandans, despite the fact that it has been there from 31st, 2003. Could you explain this? I mean, do you also feel the same, or you just they know us and we are doing what we need to be doing?
Thank you very much, Anangwe, and good evening to our viewers. Rwanda Medical and Dental Council, as a regulatory body, as you rightly said, came into existence on the 31st of January in 2001, but essentially started its activities from around April 2004. And initially it was a regulatory body for medical doctors. And later on we realized that we had to regulate another component of our colleagues called dental surgeons. And it's then that we incorporated the medical and dental surgeons into the same law as it has been updated up to around 2008. So you're right. Regulators everywhere are not popular people. And this might not be the reason, but the regulatory activities have taken place ever since 2004, and from the time the council was established, essentially it's been recognized over time, and we expect this to keep getting much better. And maybe to contextualize the real activities that we do, as you rightly said, our major role is to regulate the practice. And the major mission is essentially to protect the population as we guide the profession. This is critically important.
Protect the population as you guide the profession.
How do we do this? Essentially, we are talking about medical practitioners, and you're talking about dental surgeons, or healthcare professions in general. But we know that they are incubated from medical schools and dental schools. So the primary responsibility actually starts from when these students have joined the medical and dental schools. So we start following them up through what we call, we start actually registering them to see whether indeed their entry and the entry criteria in this perspective were followed. Because at times in some countries, you find that they do not have strict criteria under which a medical or dental surgeon are admitted in medical schools or dental schools. And so we start following it up from day one. And we do regular audits of the medical and dental schools. And, you know, when you talk about medical schools, we only have 2 currently, and we may have other 2 coming next year. We only have a single dental school, which came into existence 4 or 5 years ago. So we may have the first batch of graduates at the end of this year. So after that, when they have gone out of the university,
yes,
we follow them up in the internship year. So we place them in different places with the Ministry of Health, because we have a national internship committee, which is chaired by the permanent secretary of the Ministry of Health, co-chaired by the chair of the Rwanda Medical and Dental Council. Then we ensure that these previous medical and dental students have now been trained with the knowledge, attitude, and practice, and are skilled enough to be allowed to go into the marketplace to practice independently. Then after that, we register them as practitioners, as independent practitioners, who go to different places and then get deployed or go for postgraduate education and specialize in different fields. So we basically follow them from day one when they have enrolled into medical and dental schools, and follow them during their practice years. And essentially, basically 10 to 12 years is not much. And the fact that we are doing the regulatory part and doing it in strict areas, and it's unethical to advertise ourselves, I think people that need to know us know us.
People that need to know you know you. I mean, I'm going to pick it from there, Sam, because, you know, he says regulators tend to mostly be unpopular. And, you know, as a person who's practicing, you know, a professional dentist and also, you know, a citizen, I mean, should that worry people? Because most of the time on a day-to-day basis, you go to a hospital, probably you find that there's a problem, you know, that happens in that particular hospital, as far as matters of, you know, malpractice are concerned. Not knowing, or the regulator not being popular to you, so that you're able to know if you're supposed to report there or not, should that concern you personally?
I believe that it is very important that the general public get to know that there is a regulating body that deals with their problem. Like we know the police is there to handle different criminal cases. Same as applies to the medical or any other professional counsel. So that we know where to report. Actually, it's one of the problems that cases go unreported, especially the usual citizen who has no right to information. How do I report when I don't know the existence of something? So I find it very important that we should know that, and the council can handle our cases when we know where to report. Right. Basically, that's why most of the cases go unreported.
Right. Dr. Does that hold water?
Yes. I think that holds water to some extent. Let's see, where actually do we get cases that we follow up?
Because you say those who need to know you
know you. Yes.
So who are these that don't need to know you, and those who really just need to know you? I mean, could you substantiate?
What I would like to what I would have said is that as we serve the population and guide the profession, and as the organization is still basically in its infancy, I think we've tried the best we can. And how do we get news about potential malpractice? Because it's only malpractice when it has been, when due process has been commissioned, and these are institutions of government that we collaborate on day-to-day basis.
Right. The argument, Dr. just to cut you short, would be that probably this is a safe haven for you. It's safer for you not being known, and so that the Ministry of Health gets, you know, the lashing, the beating, the backlash, if in case of any, so that you hide yourself behind them? I mean, if someone thinks that way, would they be wrong?
I think they would be, because the Rwanda Medical and Dental Council, one, is not in hiding. We operate in broad daylight. We have got an address. We are on all social media. We have a place where we work. We have a headquarter, and we have staff members that are there, and we have toll-free numbers. Maybe what we haven't done to the best, and that we shall probably improve on, is to communicate clearly to the population that we serve, to make sure that we provide links to the National Police, to the National Prosecutions Authority, to the Ministry of Health. And this is essentially part of the communication strategy that we are coming up with to ensure that more people know us. But let's say, for instance, the medical funders or the medical aid schemes or the corporate clients to many service providers. These people know us. That is the insurances. They know whenever they suspect evidence of fraud, whenever they suspect evidence of, things to do with malpractice,
they know where to
to find us.
Right.
And what I can say is that, these alleged malpractices take place in our healthcare system. And from the health centers to, from the posts, the post centers, health centers, district hospitals, provincial hospitals, and referral hospitals, they all know us because it's mandatory that every practitioner gets registered, gets licensed, and cannot be allowed to practice unless, and every district hospital or every district in this particular instance, they have our contacts. Fine. And they are known to each and everyone. That's
right. Fair enough. But then where does this leave the common mwananchi like me, who doesn't have to come to you for registration, but I have a case of malpractice that probably happened to me, negligence, maybe my kid has had a problem in a certain hospital? Do you concern me? Do I concern you? Is there any where we meet?
Yes, you do. Yes, you do. And Anangwe, what I would like to bring into perspective is that, there is one thing. You've taken your kid to the hospital, and the service that has been provided to you does not satisfy you. What does this mean? What does it imply? Maybe it does not satisfy you because you probably waited for long to see a doctor. And what were the hurdles on the way between you and seeing the doctor? Maybe the cashiers were impolite. Maybe the cashiers were not forthcoming. Maybe you didn't have somebody to protocol you, to walk you through and up to the time you see the doctor. Or the problem happens to be that maybe you saw a doctor, and this doctor maybe prescribed wrong medications.
Wrong medication.
Prescribed wrong medications, or was supposed to do a certain procedure on your child and did not do it. And maybe had the means to do it, but did not do it. What does this mean? This means that you've say, for instance, gone to a hospital or a clinic X. The first primary source of information is this clinic, because they have administrative responsibility to ensure that this person that they employed serves their purpose.
And they have failed to serve. Where do you come in?
And if they do,
yes.
then you come to us. Then you come to us. And we are on toll free. You can call us on 3024. You can go to www.rmdc.rw. We are becoming a relatively modernized country. And we believe that does not permeate well to the rest of the population, the majority of the population, who probably don't know how to use internet, maybe don't know what the toll-free numbers are, but that still remains a structural challenge as opposed to a systemic challenge, which can be rectified with time.
Right. Sam, as I go to the super wall or the touch screen to open a few figures here, I want to hear from you. He says, way back in the 2000s, that is when actually the institution came up, and there have been a lot of adjustments and changes and growth. We are in 2018 today. Many years have gone by. You know, vote of confidence or vote of no confidence, based on the fact that he says, you as a citizen, if you have a case of malpractice, a case of medical negligence, you have to come to us and report that case. How would you judge them?
I think I would just simply say that the first and the foremost is, like the hospital has the complaint mechanism, like written on the wall. If you're not satisfied, call this number, put on the suggestion box. It is very easy. If you're not satisfied, if you have experienced any negligence, any malpractice, please, this is where the medical council is. Yeah. They can handle your case. I think we still have a journey to accomplish. And maybe if that mechanism of getting themselves to be known in the hospital, which is the easiest way, because you will not find anywhere the patient except in the hospital. And that is the first entrance. So I think that's where the bottom line is.
Right. You did answer my question. Vote of confidence or vote of no confidence?
I think they still have a journey.
I didn't ask if they have a journey or no journey. Vote of confidence, no confidence.
Vote of confidence.
Vote of confidence.
Vote of confidence. Yes. You have confidence in them.
They have done some good job.
They have done some good job. Right, let's take a look at some of the cases that we have had. This is actually information from the council, the cases of malpractice, according to that particular report as far as 2008 to 2017, right? 2008 to 2017. These are the numbers for you. Obstetrics and gynecology, 69%. Of course, pediatrics, 69 cases, 26 cases, and these are 20 cases as far as surgery is concerned. Other specialties, 10, and of course internal medicine, 8, and then anesthesia, 5. Right? Okay, so this is definitely what we have concerning that. Definitely, this is another one coming in from the year 2008 to 2017. We had 4 cases in 2008, 5 cases 2009, 6 in 2010, 13 in 2011, 8 went down a bit in 2012, 12 in 2013. We still had the 12 in 2014, then shot up 27, 34 in 2016, and then 27 in 2017. I want you to help us understand these numbers, Dr. Rudakemwa. These are the numbers, and I want them to remain on the screen so that we can be able to have our viewers understand this. This increase, going up as far as this is concerned, I mean, is it a major cause of worry for people? I mean, those who are seeking medical attention?
No, it shouldn't be. Actually, this is a testimony that people are reporting cases. This is a testimony that there is an improvement when you compare 2008 to 2017. Cases are being reported. Because remember, this is just showing the cases that have been reported, that have been received in our archive, and that have been dealt with. So every time cases of dissatisfaction, cases of alleged malpractice are reported, that is a good thing, because it shows that people are coming forwards and therefore have trust and hope in the dispute mechanisms that are in place by with the Rwanda Medical and Dental Council, and actually other health professional councils. Because remember, Rwanda Medical and Dental Council deals with doctors and dental surgeons, like the Allied Health Professionals Council also deals with the Allied Health Professionals Council, and the Nursing Council and the Pharmacy Councils. They also equally have a number of alleged malpractices that they deal with. Right. And so this is essentially cases to do with the medical and dental.
If we can have this back on the screen so that we can just have some chat about it. You know, these numbers, 4, this is 2008, and 27 in 2017, this is for the whole country.
Right.
This is the whole country.
Yes.
And you say that with this increase from those years up to 2017, then this shows a growing level of confidence in reporting.
Correct.
But if you look at that gradual increase, I mean, these are very small numbers. Does it show that we have, very few people in the entire country reporting, and we feel that this is something encouraging?
What this is representing is that probably there are a lot of cases that are not reported.
Go unreported.
Yes, go unreported.
So it's not yet time for us to pat ourselves on the back.
Exactly, exactly. And you know, in the regulatory mechanisms, you always want to avoid even a single case being reported. So the fact that we have sensitized the population, we have sensitized, actually even self-reporting, the directors of the hospitals, asking them that if there is any case that you think has been mismanaged, please report it, such that, because it's like doing self-audit. When you do self-audits, then you provide a chance for growth, a chance for doing better. And this is what we have conceived in our system, because, and you must remember that most of our institutions are under accreditation system. And therefore, most of these cases actually have been reported as a consequence of self-awareness and the fact that once a case has been analyzed, looked into by the peers, then one, if this case didn't die and probably just got injured,
yes,
or was not happy with the healthcare system, then there is something that you can correct. If this patient died, then you have an opportunity to make sure that you are going to put safeguards against any more loss in the future.
Right. And
you need to also note that in your statistics you seem to display that, or to show that the obstetrics and gynecology cases have been over-reported. One, you must realize that with the MDGs and the SDGs, we are under strict instruction that all the maternal and infant mortality cases must be reported. And this is also something that has come because it is the right thing to do if we are to ensure that we comply with the World Health Organization standards and guidelines.
Yes.
We must make sure that we report cases without any fear or favor, without anything that you have to hide. So these are things that are put across, and then they are put there for the council to follow up. We appoint what we call the preliminary investigation team that goes and establishes facts and figures and comes up, forwards this report to what we call the professional conduct committee, which sits, analyzes, and sees the roles and responsibilities of certain doctors, of certain other health practitioners who are actually handled by other regulatory bodies, as we said. And this has come to our understanding that we cannot afford to do anything that is not in accordance with the standards and guidelines. And that's why we say whatever has come up has actually taught us much in terms of how we should build and strengthen our system, both at regulatory and at practice levels.
Right. Rosine, when you look at these numbers, I mean, what touches you? What comes to your mind? Does it worry you that, you know, we have only 27 in the whole 2015 in the whole country? Some people argue that probably this is underreporting, and there's so many cases that go unreported. What happens to them? And even the numbers that those that have reported, what next? What has happened out of those reports? I mean, what comes to your mind?
I think there are a number of contributing factors. One, there is ignorance to know whether this is a case of malpractice or negligence. Number two, either you know it and you're scared to even report or to be against the doctor. Number three, even those who know their rights, they can't afford the procedures. For example, let me tell you, from the legal perspective, the patient has the right to file a case to the council, and has even a right to file a case to the civil court. That can happen anytime. Even you can first go to the council if you want, or you can do it even before that.
Right. So Dr. Rudakemwa, for me, I want to know, I mean, the people who are watching and they're saying, fine, they have those numbers. What did they do with them? Today, I'm still following up on my case. I have people who have told me, you know, in confidentiality that, you know what, we're still following this case in and out of court, trying to find how we can be able to be helped, get compensation, further treatment, whatever it is. What can you tell people who are in that state?
Yeah, I would like to say that, one, we are not satisfied with any levels of malpractice. Because one case is too many for us. Two, we would like to inform the public that is actually following us that when it goes, when it comes to medical practice, if you go back to the 5th century, to the Hippocratic Oath,
right,
no medical practitioner or no health practitioner goes to the hospital, to the health center, to the clinic with an intention to do harm.
But those who are just absent in their workplaces,
those ones deserve administrative sanctions. Those are not professional. If you don't go to work because you are drunk, or if you don't go to work because you are indisciplined, that goes beyond the professional malpractice. It is something that should not be tolerated at all. But let's say somebody that has managed to go to the hospital, seen the patients. What I'm trying to say is that this is civil. There is nothing criminal about me taking a patient to theater, and this patient having done the best I could, this patient still goes ahead and dies. When we establish facts that this doctor, Dr. X, has done the best he could do in the present circumstances, we actually have exonerated so many, despite the outcome of the intervention that was done. But we have, however, noted that there are so many cases of where somebody could have done something to save this patient's life,
and they
don't do.
Yes,
we have noted where patients were advised to do something X and they didn't, which could have contributed to their to the outcome, and they didn't do. This is a multifaceted challenge that we need massive health promotion, massive education, and then, as we do, make sure that our doctors have the requisite knowledge, have the requisite attitudes, and the practice is therefore informed by the two, and this becomes impeccable. And this is what we do on day-to-day basis.
Right.
Because even when we sanction, because as you saw, I think you didn't show your last slide.
Yes.
You see that we sanction these doctors. We sanction them
6 months,
without
3
fear.
months.
Yes, without fear or favor. We have even deregistered some because they have done things that are incompatible with our profession. And therefore we say, we have dissociated ourselves from you. Please go and do other business. Go and sell tomatoes or something else. You do not qualify to remain in this profession. And this one we do not because somebody has told us to do it, but we think and believe that this is the right thing to do. And you have done so many of these. And you need to note that our sanctioning does not have to be punitive. It has to be corrective. It has to be corrective. You're talking about somebody failing to come or turn up for work. You need to establish beyond reasonable doubt that indeed this person is fit to practice. This person, doctors get sick like anybody else gets sick.
No, we're talking of lives,
yes.
Dr. We're talking of lives. We're talking of people's welfare,
yes.
affected someone's life that could have been saved because this doctor was...
Actually, I wanted to go to the compensation part.
Yes,
the government has put in place a mechanism.
Yes.
I mean, having said that, what we do at the hospital, what we do in our health facilities is civil, has nothing to do with criminal. There is no intention to do harm. The best we do is to try and save the patient's lives despite our personal weaknesses.
Right. Can we talk about
what
the
I'm
compensation
saying,
when we come back from the break?
Yes,
So we
sure,
give it
sure.
proper timing,
Yes.
and then Rosine can also jump in and tell us what she thinks about that. But of course, before we go there, let's just quickly take a look at some of the social media trends that are going on right about now. As far as Twitter is concerned, all you need to do is use the hashtag InFocusRW. Let's take a look at what you're saying on Twitter. I have Agaba Gorgeous who says that what is the ready to done to the doctors? I'm sure you're trying to ask what is going to be done to doctors who can't take good care of patients who go for treatment in hospitals, actually public hospitals. They should do a survey on how hospitals take care of sick people and what patients have to say on where they get treated. All right, so what action can be taken to doctors who can't take good care of patients who go for treatment? Very quickly, what can we tell this gentleman who's tweeting about doctors who cannot take good care of the patients?
The doctors that do not do what they are supposed to do should correct themselves. Otherwise, they are in the wrong business.
Right.
They are not supposed to be where they are today.
Okay, Abiola Isaac says that medical negligence begins with little efforts made to improve customer care and the relationships at major private clinics. Definitely, these are some of the tweets that you've been sending us. Of course, we will be coming back in a very short while to sample more of those particular tweets. Keep them coming. Use the hashtag InFocusRW. When we come back, we'll be moving the conversation forward concerning the issues of malpractice and negligence at the medical facilities and institutions. Do stay with us.
Many people have been asking what we have been up to. Well, we have told the different stories from decision makers, but this time round it will be different. We will be getting head to head with various influencers and get to the heart of the matter. It is not an easy ride, but we'll endeavor to get you there. It will be insightful, informative, and at times we will agree to disagree because we are the bridge to your leaders.
Right, thank you so much for still being with us. It is In Focus, and of course, you can definitely be part of this conversation. I would love to hear from you, your personal experience, or what you think about the issue of medical negligence and malpractices at our medical institutions. Feel free to send us your tweets at the hashtag InFocusRW. We'll be able to sample it right here on the program. And of course, I have one tweet from DJ Nano who says that a medical negligence discussion, of course, is there a body that regulates or checks on regular basis that medical practices are being followed and hospitals are up to date with the right personnel and equipment? Dr. This is definitely what I was telling you when we began the program, that various people do not really know whether you exist or not exist. What are you going to do after you leave this show tonight?
Yeah, thank you very much, Anangwi. Yes, a body exists, and as you saw, the Rwanda Medical and Dental Council has been in place for more than now 12 years. What we are saying is that we need maybe to pull up our socks, make ourselves seen. You must realize that being a regulatory body, we only depend on the contributions of our members. So, and we are trying to see how the regulatory landscape can actually become a budget entity such that the government supports this, because
you want to say the government doesn't support it?
Not as such, not the best that we would have wanted.
What would you want?
There's no regular vote, I mean budget vote for the professional regulatory body.
How would you want it to be like?
To finance the budget. That we want, you know, when you're a regulator, you need to inspect, you need to regularly visit these practice areas. And I need to mention that actually the practice areas, the hospitals, the clinics, the facilities are regulated by the Ministry of Health. We regulate the practitioners. And we are in constant discussion with the Ministry of Health as a policy and strategy maker, we should decentralize the facility regulation to the Rwanda Medical and Dental Council. But to date, we only regulate the practitioners, we peer review their papers, we credential and privilege their practices, we register and license them, we ensure that they undergo continuous professional development to make sure that they are at par with the rest of the practitioners elsewhere. And we ensure that whenever somebody does something wrong, we put him to his foot or to his feet. And basically what we are saying is that all these require budgets. We need technical support at the Secretariat that is fully functional. We have skeleton staff, and those need definitely financing. But the good thing is we are in constant discussions with the government.
Right.
It's not that they are refusing to give us the money. It's just that we probably have a small cake that we are all sharing. And so we, to some extent, understand the challenges. But that does not mean that essential things like basic regulatory activities cannot be done, because you cannot have a proper medical practice, as you've seen from our followers, without a thorough regulatory landscape and regulatory framework in place.
Right. Okay. I mean, Sam, do you feel that money matters is the major issue that you think the regulator needs to be able to nip in the bud issues of medical malpractice, medical negligence? I mean, what is it that you would tell him to his face, or the medical practitioners, or the whole situation as it is, to bring it to the reality as it is on the ground?
I think that very important is that how many cases they were reported, how many of them that have been successful. That is number one. Number two, if any, like, for example, the law talks about suspending someone for a quite number of 6 months.
Yes.
That equivalent to people's disability or the death of someone.
Right. Before you go far, can you respond? I mean,
No, thank you very much,
Yes.
Anangwi, and thank you. You know, we said, though I didn't elaborate much, the government has put in place the medical liability law. And this medical liability law is going to be determining means and ways of compensating people that have had complications secondary to interventions of the doctors or dental surgeons. And this essentially serves as a medical protection. And having understood that no doctor goes to the hospital or to the clinic with an intention to do harm, but harm happens. And when harm happens, the issue is to correct, not to punish this doctor, is to correct. And therefore, if you look at the practice elsewhere, you make sure that this doctor understands that he erred or she erred. And therefore, once she or he understands that there was a mistake, then he or she works to make sure that he rectifies.
The argument that he's bringing on board here is that the doctors seem to be protected
They are not.
From punishment.
No.
At the expense of the lives of that patient or that relative, or even the physical being of that patient who has had their lives messed up because of that malpractice or negligence.
What we are saying is, actually, to be specific, more than 90% of the cases that reach us have been solved, at least up to date. And as you saw, we have about 13 cases remaining that will be sorted out next week. And in the next 3 weeks, we shall be sorted with all the cases that we have received. So that means the question is, are the punishments that we give matching the disabilities that the patients have endured? That's why we are saying that there is going to be a liability insurance, which essentially should compensate in real terms with the disabilities of different patients. Otherwise, you cannot have a punishment. It's like the government of Rwanda saw it fit to remove the...
Place, right?
Can I first finish?
Let him finish, yes.
We saw it fit to remove the death punishment, because killing people or heavily punishing people will not rectify the situation. We need to correct and then punish. But you cannot only punish and expect things to work the best way you want.
Right.
I think from the perspective of the indemnity insurance, first of all, this law is already in place. But if I can ask the doctor, how many healthcare providers, or I mean healthcare professionals, that already have this insurance apart from the health facilities? If you go down there, trust me, you might not find anyone with an insurance practice.
Let me just tell you that this is common knowledge, that the ministerial orders that are supposed to implement the liability law have not yet come in force, and they are yet to go to the cabinet. This is a fact. You can check. And so when they go to the cabinet, there is one that is supposed to come from the Ministry of Health and another one from the Ministry of Finance, determining the tariffs of these medical covers. When they come out and become gazetted into law, we are going to make it compulsory. It becomes compulsory. So it means you cannot get licensed by any health regulatory authority without having this without this liability insurance.
The law is not yet approved.
Yes. No, the law was approved, but what is not yet enforced is the implementation instrument,
which has actually taken long, Dr. And there have been complaints as to why it is really taking this long.
Yes.
But let me bring you to this particular issue, which Bana is saying on Twitter, and she says, patient safety can't be guaranteed in courts of law. It is a function of many things, including having well-trained and motivated medical professionals working in adequately equipped hospitals. Now, we have heard of medical practitioners, doctors, who own pharmacies, who have private clinics, that, you know, at the end of the day, they are either dividing their attention, not being able to function, give the full attention to this patient. And the argument has been, I need to fill up my basket because I'm not being paid adequately, as she's saying here, as part of the motivation. What have we done in this end? I mean, are they justified to say that they're not well paid, they're not well motivated? That is why they have other side deals that make them either be out there for too long to even attend to a patient who later on dies.
Thank you very much for the question, and thanks to the person that has asked that. I can state this without fear or favor and say that we now have a multi-pronged approach to retain, to motivate healthcare professionals in general. And as you are aware, we are coming from a narrow base.
Yes.
And we have reached a certain level where we can confidently say that right now we can start motivating our healthcare professionals. How are we doing this? Or how is the health sector doing this? One, we have put up a saving scheme. You know, you can't beat a saving scheme if you want to motivate your healthcare professionals. And this saving scheme is supposed to be compulsory because we know that our saving rates in the country are very low. So we need to bring this culture of saving to ensure that if you get a problem at a certain time, you can go to this and to this fund and be helped. This is going to be for all healthcare professionals. Two, we are looking into having dual practices accepted by law. You know, the labor law or the labor, the labor law talks about being allowed to practice in more than 2 places, as long as you do not compromise your primary employer. This means we are, the Ministry of Health is putting in place a dual practice, which is going to be in place and say, Anangwe, you work at Sehashuka, but you can be allowed to work at the Medical or at King Faisal without any fear. Right now, people do it, but you know you can be called by your boss anytime. So this business of people owning clinics and dispensaries and pharmacies
is going to be allowed officially by law.
No doctor is allowed to own a pharmacy. A pharmacy is supposed to be owned by a pharmacist. Doctors can run clinics, can run hospitals, but we need to be honest, and we are very honest people. So to the extent that you cannot go into any other business and still practice medicine because you are interested in money making, our primary drive is not in making cash, is not in getting fast rich. Our primary focus is to be kind, is to be honest, is to serve with humility and make sure that we satisfy the needs of our clients. Even if money comes, that should come as something to make you survive, but not as a primary driving motive for you to make money. If you are driven by money, then you are going beyond the norms and standards of being a good clinical and the virtues of being a good practitioner.
Right. So the bottom line, you're saying that in the near future, doctors will be allowed to practice from either hospital, from the central hospital or the main hospital that they are dispatched to. They can go and also practice in another different...
As an incentive,
as
yes.
an incentive.
Yes.
Is this safe? Is this not what people are worried about? That the doctor at Siashka, for example, I've come to see him, but he's not there because he is in another hospital in Muhima, and so we are all waiting here, or the nurses are the only ones who are here because it is allowed by law. Is this going to be helpful? Is this going to solve the issue of negligence?
I think one of the frustrating things is that is where you find that it is during the night. This is an emergency hospital. This is an internal medicine. This is a pediatric. Where you find that there is only one person attending those departments, and this person is stressed. This person is not going to focus with this, how many referral coming in, the emergency coming in. So this will actually, if they don't have proper mechanism to have people, in case this person leaves, who should stay? Because actually it is one of the problem is staffing, the few number of doctors compared to the patients. So if it happens that we still have this number of the health care professionals that we are complaining, and then it happens that we give them freedom. By the way, on the other side, it makes sense because if they give them freedom, that is motivation. Because if I'm allowed to practice to the private facility, and still I can practice in the government facility, that means that I have some sort of motivation. But again, leaving the fact that if we don't increase the number of the healthcare professionals, that will remain as a problem.
It will remain a problem.
Eugene,
Chairman,
you know, even Rome was not built in one day. What we are saying is, you know, in 1996, we had less than 100 doctors. Today we are boasting of more than 1,500 doctors, with 443 specialists. We didn't have more than 10 specialists then, and more than 50% then were public health specialists. Today we have clinical specialists. What I can say is, nowhere in the world, including the US, can you boast of having Eugene Anangwe as your only doctor. He can't work elsewhere. So these are innovations that are trying to be put in place to make sure that we attract people to come, remain in the public health facilities, go into the private health facilities. And by the way, remember, even the health private facilities, they are treating Rwandese, or they are treating people who stay in Rwanda. And so this serves as an incentive to probably add to the little money that the government can afford to pay, because I think they would have wished to pay us 10 millions a month because of the work we do. Today I was at work from 8 and I just left at 7.
Right.
So this just means that you cannot have a price tag that you can attach to a doctor's commitment in a hospital.
Right.
So what we are trying to do is to minimize the risk and scatter the risk. As you minimize the risk, then you incentivize these doctors.
Right.
And therefore, they will definitely be in the right place at the right time with the right people.
My question is, the big number belongs to the public hospitals compared to the private hospital. If we make these people move, we complain to have few specialists. If we leave these people to go to the private facilities, how many that huge number that is left behind in the
So I think this is something we'll definitely be able to dig a bit deeper into. I have another tweet here which I really would love to bring to your attention. And it says, it is shocking to hear how a maternity center like Kwa Nyirikwaya, right, has one doctor handling over 200 pregnant women cases at a time. Another one says, Gakindi at King Faisal, same case. Claude here at Muhima, same thing. Where are the doctors? Is this something that is on your table? Are you aware of this issue?
That is not true. That is not true, because I can confidently tell you that we have about, let me just give you the figures. We have about 231 doctors in the private practice.
Right.
And we have 787 doctors in the public sector. We have actually gyne and obs are the specialists
Biggest number.
with the highest number of specialists. So what I can tell you, and maybe one can also say that the majority of the specialists work in town. They work in Kigali City.
Right.
What I can tell you with confidence is that it's not true that Rwanda, or what is commonly called Kwanyirinkwaya,
right,
has only one gynecologist and obstetrician, because we have, at least I know, more than 3.
Actually, they have more than 6.
When you talk about Gachinda at King Faisal Hospital, we have today, we have 3 full-time consultants, minus Gachindi. Gachindi is now a part-time. I'm sorry to discuss about names, but right, I can confidently tell you that we have full-time specialists at King Faisal Hospital and have about 3 part-time specialists coming to King Faisal Hospital. So, whereas it is true that these doctors alternate at work at different times of the day and night, what is true is that whenever you get busy at work, you have a right and a responsibility to call for help. Even if that person is not working in your hospital, and that is a calling for medical practitioners. I can be called to go anywhere when they need me, as long as I'm licensed to practice in Rwanda.
You should be able to go
and then
there.
The rest gets arranged administratively.
Right. Sam, we are closing, and I just want to hear very briefly from you. Moving forward, this issue is something that we cannot conclusively conclude right on this particular program. I know of cases of people who are still telling me, you know, I have this problem, we're still following up on this. Where do we go from here? How do we deal with this issue? What would be the final solution to this issue?
I think I'll first go with, first of all, what is medical negligence? First of all, the duty, the doctor owes a patient a duty to give care. When that duty is violated or is breached and it causes any damage, injury, either financial, any emotional,
right,
then that becomes the case. So when should the patient know this is the case? That is a major problem. Another challenge we have is that even the hospitals are covering those cases. If I'm to go out, where should I go? How can I access information? We even have doctors who refuse to give us our medical record. The article says a patient have a right to the copy of the medical record.
And these are cases you know of?
Yes.
Or we are just throwing blanket statements?
If you ask the audience,
yes,
they actually tweet that. We have some doctors that refuse to give medical records until we complain to the hospital management. That is unfair.
Right. I mean, Dr. Chairman, again, this part of the unreported cases, I mean, are you aware of these ones? Are they among the numbers
what
we
I
talked
can
about?
tell you is...
as we move towards the end of the show.
What I can tell you, thank you, Anangwe. One, what we can say is that there are indeed issues of communication. We probably haven't communicated adequately to the public. Right. And part of it is that RTV is very expensive. RBA is expensive. So... but we are ready to come whenever you call us. Two, what I can say is that the way things were 5 years ago is much better today, and we can only hope that things are going to get better. Three, we are very mindful of some inconveniences that patients face in different hospitals, part of which asking for your medical report and you're denied to have it. Actually, having a medical report is a right. It's not optional.
It is actually in the Constitution.
Yes. So if anything like that happens, and maybe my colleague, medical doctors and dental surgeons that are following me,
This
kindly
happens.
provide,
We're actually out of time. We're going to be cut short. Let him
can
finish.
you
Yes.
kindly be providing medical reports whenever they are asked, because it's the patient rights.
Yes.
Especially when
And-
they are not satisfied
Yes.
with your
Yes,
results.
and two, second opinions. I can come to you and go to him and go to someone else. That is a patient right.
So it's important to seek
important
second
to
opinion.
second opinion.
Don't just take one opinion. And that would help you, right?
Yes.
Okay, thank you so much. I mean, because of time and the news has to come in, we just definitely have to leave at that particular point. But of course, we want to say a big thank you to all of you who have been watching. Of course, this is a conversation that actually has to keep going on. We have both of the panelists right here. They are on social media. That means you can still be able to get your questions answered if you have any. Dr. Rudakemwa, your Twitter handle is?
At Irudachemwa.
At Irudachemwa. You definitely can be able to still ask your questions, follow up, and be able to understand the questions or concerns that you may be having from where you're watching. Thank you so much. As always, we cannot be able to end these conversations here, but of course we start them for them to continue on social media or any other platform. Let's keep talking, and of course we'll see you again next week, same time, same place. As always, my name is Eugene Anangwe. Good night.